Welcome back to another lecture of Dental Pathshala, where we help you understand and learn dentistry better and easy. When this video is a continuation of the express revision course for periodontics. And before we get started, make sure to subscribe to the channel and hit on the bell icon so that you don't miss any of our future videos. And also you can check out the link in the description below for the notes of this particular video. And if you are looking for reading the more interesting notes in dentistry, you can also check out our website www.xdo.com. So guys, let's get started with the today's topic, which is the furcation and the treatment of the furcation. So what do we mean by furcation? Furcation means that there is a division of the roots. So that is what we call furcation. Now we know that this division of the root, that means there are two roots, there are three roots present. These all happen in the multi-rooted teeth. So there is no furcation in the single-rooted teeth. So actually furca is a Latin word which means the fork. So furcation is an anatomical area which is usually seen in the multi-rooted tooth. So where there is a diversion of the root, we say is the furcation. So furcation is basically a complex area that is actually difficult to clean with the normal periodontal procedures. So with the normal periodontal instrument, it is very difficult to clean the areas of the furcation, and the presence of the furcation involvement is actually a finding for advanced periodontitis. So in case if we are finding the furcation involvement in any teeth, that means the teeth has progressed to the advanced stages of periodontitis, and it is very potential to the less favorable prognosis for the teeth which is affected. Now it again depends on certain etiological factors, like how is the anatomy of the root, how is the root trunk, how is the root length. So if I say that the roots are fused roots, suppose, and there is a furcation involvement, then the procedures which we'll be talking about are actually very difficult. So that case where there is a fused roots, that is not a good candidate for the treatment of the furcation. And if we talk about there are short roots, suppose if the roots are present and these are short. So what does that mean? If the roots are short, that means the PDL attachment that is also less. So we know that PDL provides the stability. So in case if the roots are short, that means support to that teeth is also compromised. So in case if there is a furcation involvement for a short tooth, then it lose all the support. So that is the prognosis of that tooth is poor. And if we talk about, suppose if there is a furcation involvement in long tooth, if we compared with long root or short root, then in long root there is sufficient amount of attachment. So even though there is a furcation involvement, there is some attachment of the PDL to the bone. So that means the tooth will still be non-mobile, or the tooth still has got some sufficient attachment to meet the functional demand. So all these things are basically the etiology. So depend on what kind of the root structure is present, what is the local anatomy. So all these factors actually plays pretty important role if we talk about the furcation involvement. So let's begin with the chapter. We have got certain types of furcation. So we'll be talking about the types of furcation. So we'll be talking about the root complex. In that we have the root trunk and root cone, and then furcation entrance, fornix, a lot of things we'll be covering. And guys, this particular diagram is of neighbor's probe. So neighbor's probe is basically a probe which is used to measure the furcation. So we engage this probe, we engage into the root anatomy. So suppose these are the roots. So suppose here these are the roots. So in case there is a furcation, we engage this probe into the root and then we check. So this probe has got the markings, and you can see here there are certain markings in the neighbor's probe at 3 mm, 6 mm, 9 mm, 12 mm, and you can see that this probe is a sickle shaped probe. Sickle is this instrument which is used to cut the grass. If you have seen any point of time cutting the grass manually, so this is a kind of sickle shape instrument which has got the markings between 3 to 6 and 9 to 12 millimeters. So guys, this neighbor probe is used to enter and measure the furcation. So it is used to measure the difficult to access furcal areas. So we use it to measure the furcation. Now talking about the parts of the furcation. So as I've told you, we'll be talking about the root complex, furcation entrance, fornix, degree of separation, how the roots are separated, what is the divergence between the roots, what is the coefficient of separation. So all these are pretty simple terms. Now if you see root complex, what do you mean by root complex? First of all, break the term. Root complex means we'll be talking about the root first of all, and then we'll be talking about some kind of a complex. So that means it consists of two parts. So it's a complex, that means it consists of some parts, right? So this complex consists of, see, this is the whole root, right? From the CJ, if you see, up till the entrance of the furcation is the root trunk. So up till the entrance of the furcation, if you can see here, from the CJ is our root trunk, guys. So there are two parts to the root complex. One is the root trunk. So trunk of the root. If you have any time in your childhood drawn a diagram or a picture of a tree. So how do we make a tree? First of all, we make a trunk and then we make these branches. And on these branches, we make these leaves, right? So this is how, guys, we have always made this diagram. Or if you can made a diagram of a plant, or you can made a diagram of a tree. And if you remember, we have talked about in the plants in the biology that this is the trunk of the tree or trunk of a plant. So say likewise, till there is a branching, so this is what do we call the root trunk. So before it branches out, we have got the root trunk. So this is the root trunk area, and the roots, the separated roots, we call it the root cones. So we have got the root trunk, and these are, guys, the root cone. So there are two parts to the complex, and we know that complex, that means complex means there are certain parts to it, right? So this is a complex. So that means it consists of two parts. One is our root trunk, and another one is the root cone. So the portion which lies apical to the CJ, whole of the portion, basically whole of the portion of the root, which is apical to the CJ, we call it the root complex, and it is covered with the cementum. So whole of the root complex is covered with the cementum. So whatever is beneath or apical to the CJ is our root complex. Now talking about, we have got root cone. First of all, we'll talk about the root trunk. So root trunk is the part which is from the CJ up till the furcation. So up till the furcation, if you can see here, guys, this is the furcation line, right? So this is where the tooth or the root furcates, right, divides. So up from the CJ up till this measurement is what do we call the root trunk. So the combination of the root trunk with number and the configuration of the root affects the success of the therapy. Suppose what I'm talking about is, suppose in case if there is a short root trunk. So that means if I make this diagram, and if there is a short root trunk, so the root trunk is, this is a long one, so we'll make a short root trunk. Okay, only this is the root trunk. So suppose if we have such a kind of situation where there is a short root trunk, there is a less attachment needs to be lost before the furcation involved. So once the furcation is involved and there is a short root trunk, then there may be more accessibility to the maintenance procedure. That means easily the furcation has reached. That means even a small amount of furcation involvement will lead us to the furcation. So we can easily clean this area. So that means if a tooth is having a short root trunk, that means it is easily accessible for us to clean that area, because we can also always insert all the instruments, so it is easier for us to clean that area. Or suppose if in case there are fused roots present. So suppose if the roots are itself fused, then it is very difficult to clean these roots. So that makes the tooth or the root an inappropriate candidate for the treatment of the furcation. So this is how the root trunk affects the therapy or the treatment of the furcation. So this is the main reason that we are studying all these root complex, because we want to know that how is our prognosis of the treatment. So if there is a larger root trunk, suppose I say if there is a larger root trunk, that means the root cones are short. So root trunk is larger. In that case, there is decreased chances of furcation. So in case if there is a furcation, so that means it can lead to a poor prognosis. So if there is a longer root trunk, guys, so there has to be a more bone loss to reach up to the furcation. And if there is a shorter root trunk, that means even a minimum amount of bone loss. Suppose I'm going to draw one more here. Here, this is a short root trunk. So in case if there is a short root trunk, in this case, if you see here, even a small amount of bone loss will take it to the furcation. So that is how both of these affects us. Same goes for the root cones also. Root cones is the divided region of the root complex. Basically, these are the components of the roots. So the roots which we have are our root cone. So suppose if there is a shorter root, so that means there is a less support. So if there is a shorter, suppose I'm going to make one more here with a shorter root. So if suppose this is a teeth with a shorter root, and if this teeth with a longer root. Now what happens if the teeth which is with a shorter root has got less periodontal support, right? So if furcation involved, that means this tooth has got a poor prognosis. If there is another teeth which has got a long root or say moderate root, then it is easy for us to treat because it has got sufficient tooth attachment. So in case of functional load, it can take up functional load. So this is how the root length, the root trunk, all of these things are pretty important for us to understand the prognosis of our treatment. So this is important for us to understand what is the anatomy of the root we are talking about, which is involved in the furcation. So suppose say we have got two scenarios here. One is when there is a long root trunk. If you can see here, the root trunk is long. Now another one is we have got another scenario where there is a short root trunk. Now the vice versa is the long root trunk is there, but the root length is short. So root cones are short. But on the other hand, the other scenario is where there is a short root trunk, there are longer roots. So we'll be talking about both of these situations. So in case there is a short root trunk, but the roots are long. So if you can see here, when the roots are long and even a minimum amount of infection, see suppose if there is a minimum amount of invasion. So what happens, even a minimum amount of bone loss will include the furcation. So that means there are higher chances of the attachment which is existing because the roots are long. So that means there is going to be, guys, there is going to be bone here. So that means the attachment is pretty good. If you can see here, we have got pretty good attachment. So the tooth has got less mobility. It can take up more loads. So the prognosis of this particular kind of situation is quite good. And guys, other situation we have where there is a long root trunk. In this case, what happens? There is a less attachment. If you can see here, the attachment is less in case if there is a furcation involvement, guys. So if there is a furcation involvement, there is a less attachment. That means significant amount of bone loss has to be there for the furcation, and there is a little amount of attachment. So this particular situation is not a good candidate for root resectioning. And I'm going to tell you one example of this particular kind of situation, which is, guys, is our maxillary first premolar. So a maxillary first premolar has got the longest root trunk. So there is a least furcation involvement. But again, if the furcation involvement occurs, then there is a poor prognosis. I hope that you guys are understanding it. If there is a furcation involvement, if there is involvement up till here, then there is a poor prognosis, right? So the example for the short root trunk is what we have is the first molar. So first molar basically has got a shorter root trunk as compared to the second molar. So guys, maxillary teeth, also remember that maxillary teeth has got poor prognosis. as compared to the mandibular teeth. Also guys, root morphology plays very important role. So if we talk about the root form or the root morphology, so there are certain concavities which are present. So there are heavy fluting also which is present. So suppose this is a mandibular molar here. So suppose this is the mesial side, then there is a distal side. So if we talk about the mandibular molar, say, so the mesial root of the mandibular molar, the first and the second molar both, as well as the mesiofacial root of the maxillary first molar, also we see that typically they have got a distal curve. I mean distal side in the apical area. We will see that there is a distal curvature, right? So all these things make the difficult to clean. So it causes a problem in maintenance and the debridement of the furcation involved root. So it makes it difficult, it makes it a poor prognosis, as well as if you see there is a fluting or concavity which is present in the distal aspect of this root. So in case of a maxillary molar also, maxillary molar, we see on the distal side. So on the distal surface you will see a concavity which is present. So suppose this is the root and you will find a concavity which is present like this. So it makes an hourglass appearance. Hourglass appearance like this, right? So it makes it this kind of hourglass kind of appearance. So it makes it difficult to clean or maintain this particular root. So all these things, also root morphology, what is the root form, plays an important role. Also guys, the same with the mesial root. We also see the mesial root of the, let me write the mesial of the mandibular molar. So in the mandibular molar, we see the same thing in the mesial root. So that is also kind of an hourglass. So it makes it difficult to clean that area. So it causes a problem in the maintenance. So there is a depth up till 0.3 millimeters we find like this. So guys, talking about the furcation entrance, very easy to understand. What do we mean by furcation? Furcation is the area where there is a divergence of the root, right? Furcation of the root takes place. Entrance means where the area from where we enter into the furcation. So that means suppose if this is the buccal surface, here we have got the mesial surface, then we have got, see, suppose guys, this is the maxillary first molar. If you can see here 3 roots. So this is a maxillary first molar. Then here this is the palatal root, right? Buccal, then this one is the distal part. So if you can see here guys, furcation entrance, that means from where we are entering. So this is the furcation area, this one, and from the entry of the furcation, the entrance of the furcation is the furcation entrance. So this is very easy. So this is the buccal furcation entrance, this is the mesial furcation entrance, then guys here we have is the distal furcation entrance. So there are 3 furcation entrance you can see. So the transition area between the undivided and the divided part of the root. So guys, there is also furcation diameter. So what is the diameter of the furcation? So we say that 1 mm of the furcation diameter, is seen in almost 81% of the molars. Then guys, 0.75 millimeter of the furcation diameter is seen in 58% of the molars. And if you see here, buccal furcation entrance guys is wider than the lingual one in case of mandibular molars. So guys, in case of mandibular molars, we have the buccal furcation entrance wider than the lingual one. Lingual furcation entrance. And in case of maxillary molars, we see that the mesial is wider than the distal, is wider than the buccal. And this is the reason that only curettes cannot be used for the preparation of the root in case of furcation areas. So guys, talking about the next one we have is the fornix. So fornix is basically the roof of the furcation. So if we turn the tooth upside down, this is a diagram of the root upside down, and the roof, if you can see here, of the furcation, basically the one in the green color. So this part is the fornix area. So this is the fornix. So entrances are the transit between the divided and the undivided. So fornix is basically this area. The entrance of the furcation is the fornix area. And guys, before degree of separation we have got the interradicular dimension. So interradicular dimension means, inter means, so let's write it here, interradicular, radicular word is for roots, right? So inter means in between. In between the roots, the dimension what we have, that means the measurement in between the root is what do we call the interradicular dimension. So this is also again plays a very important role. Basically interradicular dimension is the separation between the two root cones. But suppose if there are fused root which are present, so in that there is no interradicular dimension. That case there is no access, there is no visibility. So that is a situation which makes it difficult to treat the furcation. So and the teeth, the other way we have got the teeth which has got widely separated root, which has got this one, the kind of a, this one kind of a root we have where there is a widely separated root we see. So that kind of situation we get more treatment option, and it is very easy to clean because there is a accessibility, so that can be easily treated. So also the interradicular dimension plays very important role, because if they are fused root or very closely approximated root if they are present, so that make it difficult to clean, to do the scaling and the root planning or any surgical procedures. So next one we have is the degree of separation. So guys, degree of separation is the angle of separation between the two roots. So this is, here we have is the degree of separation. So the degree at which, the angle at which the roots are separated is what do we call the degree of the separation. So this is the angle of separation between the two roots. And then we have got guys the divergence. So divergence is the distance between the two roots, or we can say the length of the separation. So this is the divergence. This is the divergence. Then next one we have is the coefficient of separation. Coefficient of separation is very easy to understand. So numerator we are going to take the length of the root cone, which is, let's mark it A, and in the denominator we have is the length of the whole of the root complex, which is, let's mark it B. So this is the coefficient of separation, which makes us A divided by B. So A divided by B, which is the length of the root cone divided by the length of the whole of the root complex. So that is the coefficient of separation. And basically it tells us about the length of the root trunk, because we are dividing it, root cone divided by whole of the complex. Now guys, talking about the furcation defect. So what is a furcation defect? When there is a bone loss which is due to any periodontal disease, and this bone loss affects the root trunk and reaches up to the furcation, we call it the furcation defect. So invasion of the bifurcation or the trifurcation of a multi-rooted teeth via the periodontal disease is what do we call the furcation defect, which is usually a bone loss which is due to the periodontal disease, which affects the base of the root trunk, so which affects the furcation area. So this is the furcation defect. And if you see in a radiograph, what you will find is, guys, suppose this is a tooth. Now if you have a look at the radiograph, then what you will find is that there is a radiolucency present at the furcation areas. So this is what you will find it in the radiograph. So there are many reasons for furcation involvement, as we have talked about, because of the periodontal disease. So because of the plaque, we know that with plaque, dental plaque is the major etiology or major factor for a progression of a periodontal disease, we can say. So basically periodontal disease is due to the plaque accumulation, and bacterial plaque which causes inflammation. It goes inside the bone. When it start destroying the bone, it destroys the attachment loss, and thereby it produces a defect, which is what do we call the furcation defect. Usually we find that there is a horizontal bone loss, but in case there is an angular bone loss which is more destructive. Also we have studied, guys, that there are some local factors, like if suppose say the root length or the root trunk anatomy or the root morphology is such that it forms a furcation involvement, or it makes it difficult to clean that area. So that again plays an etiology. Suppose if there is curvature or fluting present, so it makes an increased chances for the root perforation, say during the endodontic therapy, or basically it complicates the procedure. So the local factors, the involvement of certain anatomical morphology of the root, I can say, and also there are local developmental anomalies, like say if there is a cervical enamel projection, or if there is an enamel pearl. We'll be talking about enamel pearl just in a while. So suppose if these all factors are present, that makes the involvement of the furcation. And also there are many other factors like age or trauma from occlusion, or there are other certain factors which causes the furcation involvement or the furcation defect. So the first one we have is the enamel pearl. So there, if there is any projection of enamel which is beyond the CEJ, we call it the enamel pearl. So basically this enamel pearl has got enamel itself. So this is the enamel. So as I've told you in the oral pathology series as well, so E for enamel pearl and E for is the enamel again. So this is basically a pearl which is present, right, on the enamel. So made up of the enamel which is beyond the cemento-enamel junction. So suppose beyond the cemento-enamel junction, if you find enamel in a rounded pearl-like fashion, we call it the enamel pearl, which is usually seen in the maxillary, second and third molar. So maxillary, second and the third molar. But they occur less frequently than the cervical enamel projection, and the incidence for the enamel pearl is 2.6%. So this is the average. What do we take? The range is from 1.1 to 9.7%. And they lack the periodontal attachment. Since this is an enamel, see, now you have to see it in a bigger picture, or you have to understand it, guys. Suppose if there is an enamel which is present, right? Suppose if there is an enamel which is present. If enamel is present, that means there is no PDL. So this is the reason that this particular area, it lacks the periodontal attachment. So there is no periodontal attachment in that area. So there starts accumulating the plaque, and therefore the periodontal disease. So this is the reason that I told you that enamel pearl, cervical enamel projection, all these play very important role in the involvement of the furcation. Since the enamel is present in the root, and we know that the periodontal attachment, PDL ligament, is never attached to the enamel. So since it is not attached to the enamel, there will be no PDL, there will be no attachment, and there is a rapid bone loss which we see over time. So now talking about the cervical enamel projection, guys, now there is a classification for cervical enamel projection given by Master and Hawkins. So there is a grade 1 cervical enamel projection. When the enamel projects, it extends apically towards the furcation. We call it the grade 1. Is the grade 1. So these are the grades. Then grade 2 we have is when it approaches, the enamel projection approaches the furcation. And grade 3 we have is the when it enters the furcation. Approaches means it has not reached yet, but it is close enough. So it enters, grade 3 is when it enters the furcation, is our grade 3. So the prevalence is in the maxillary and the mandibular second molars, which is quite important for exam viewpoint. So both the maxillary and the mandibular we have to write, maxillary and the mandibular second molars, which is our 7. So which is our 7 teeth. So remember that 7 is the tooth number and 8% is the prevalence. And 8%, 8 to 28%, it is found in the molars. And if both the options are there, maxillary as well as mandibular second, both molars are present, then the first one we have is the mandibular second molar. Then we have got the maxillary second molar. And then guys is the maxillary first molar. So this is the most. And guys, this, since this cervical enamel projection is present, it makes the plaque removal difficult. It can complicate the scaling and the root planning procedure, and also it can develop the gingivitis or the periodontitis, right? So talking about the classification of the furcation defect. Now, this particular video we have covered in the periodontal lecture series. So the whole of the chapter we have covered in detail. So since we are covering the hiding points in this particular video in the express revision course, so we'll not be covering the whole of the classification. Like Hamp classification, there is a horizontal bone loss. If you remember, we go below the, less than 1/3, then the grade 2 is more than 1/3, and third is Naver's probe passing through and through the furcation. So basically we see the horizontal bone loss. So there are certain classification guys for the furcation involvement, for the furcation defects. So we'll be only talking the horizontal involvement, which is the Glickman classification in this particular lecture series, because most of the questions are, almost all the questions are frequently asked from the Glickman classification itself. And once we talk about the classification of the furcation, if I'm saying simply grade 2 involvement of the furcation, then in India what we are saying is the grade 2 Glickman classification. So what we refer is usually the Glickman's classification. So we'll be talking about the Glickman classification grade 1. Guys, we have got 4 grades. So grade 1 is the minimal furcation involvement. Grade 4 is the extreme furcation or advanced furcation involvement. So we'll go from mild, moderate, then severe, then advanced. Like that we will cover the involvement of the furcation. So grade 1 means there is a early furcation involvement. That means just now the furcation involvement has started. So this is the early stage of the furcation involvement. Since this is an early stage, so most of the times the pocket is a supra-bony pocket. So it is a supra-bony pocket. And if you look at the radiograph, you will usually not found any changes in the radiograph. So there are no radiographic changes that we observe. So important points to remember is that this is an incipient lesion. Incipient means early lesion, early stage. Guys, all these points are very important. You have to remember all these points. So this is a early stage, then there is only a supra-bony pocket. So there is a soft tissue lesion. So if you probe it, there is going to be increase in the pocket depth, definitely for sure, which is due to the early bone loss. But you will not find any change in the radiograph if you see. So the interradicular bone, the bone between the two roots, is still intact. There is no changes in the radiograph we see, but still there is increase in the pocket depth. There is a supra-bony pocket. Primarily it affects the soft tissue. So this is an incipient lesion. Now guys, coming to the grade 2. So the grade 2 for Glickman, we say it cul-de-sac lesion, which is very important guys. What do we mean by cul-de-sac? So that means it is a blind sac. So suppose this is a root. You take the neighbor's probe, you enter the furcation, but you will not pass the furcation area. So the probe cannot pass through the furcation. There is a definite amount of horizontal bone loss, which we can say because there is a partial penetration of the probe, right? So let's just write all these points all together. Guys, you don't have to take down the notes. I've told you that the link is provided in the description below. to this notes of this particular video. And also you can check out our website www.x2.com, where you will find more interesting notes. You just have to click there and you have to read it online. There is no PDF, you don't have to save it. So you can just read it anytime. It will be available for sure. And nowadays everybody has got internet. If you are watching video in a YouTube, definitely you have got internet, and the amount of internet which is consumed on the Google itself is very less, because YouTube's you are already watching, right? So guys, cul-de-sac lesion, that means there is a horizontal component, the probe cannot pass it through and through, so there is a partial penetration of the probe. So guys, there is a partial penetration of the probe. So partial penetration of the probe. So there may be, it's not like there is always a horizontal component, horizontal bone loss. There may be or may not be vertical bone loss present. So for sure we see that there is a horizontal bone loss. So there is a definite horizontal component. Vertical bone loss may be present, may not be present. Right. If there are multiple defects present, they do not communicate with each other, because a portion of the bone remains attached to the tooth. That is why we are telling that there is a partial penetration. We are inserting the navel probe from one side and it doesn't come out from the other side. So there is a partial penetration of the neighbor's probe. Now guys, talking about the grade 3 furcation. Now grade 2 also guys, there is a revised classification of the Glickman, which has come in 2000, and according to that the grade 2 has got 2 degrees. So this is again grade 2, which is degree 1 and degree 2. So if you know that we are talking about the horizontal involvement of the furcation involvement, so this revised version is basically a vertical component. So degree are the vertical component. So if the vertical component is greater than 1 millimeter but it is less than 3 millimeter, then it is grade 2, degree 1. When the vertical component is more than 3 millimeter but it is not passing through and through, because if the neighbor's probe is passing through and through, then it is not the grade 2, then it will become the grade 4, right? So that is why we are telling that no through and through. So this was about we actually study this revised classification, modification of the Glickman classification, not the revised classification. This is just a modification to the grade 2 of the Glickman classification, which was given by Feld et al. In 2000. So this is just a modification of the Glickman classification. Now talking about the grade 3 of the Glickman classification. So guys, till now we have covered that there is an initial, the grade 1 we have talked about is there is an initial, incipient, early involvement, and there is only a suprabony pocket. We do not see any radiographic changes in the grade 1. We have talked about the grade 2, that we take the neighbor probe, we insert it into the furcation area. So there is insertion from one side but it doesn't come out from the other side. So there is a partial penetration of the probe. Radiograph may or may not depict any changes in the furcation involvement, right? But there is a clinical cul-de-sac with a definite horizontal component we see, right? So talking about the grade 3. Now grade 3 guys is basically what happens. Let me just draw a diagram here. So what happens, there is bone loss from both of the sides, but we still have got the soft tissue covering that furcation area. So we cannot see it from our naked eyes that there is a through and through involvement. So there is a total bone loss. So there is a bone loss with a through and through involvement. and bone is not attached to the dome of the furcation. Now you know that dome of the furcation is our fornix area, so bone is not attached to that. Bone is not attached to the dome of the furcation. So there is a complete interradicular bone loss. All these things are same thing only. So a bone loss from both the sides, facial, lingual. So complete interradicular bone loss. In the radiograph also, in the radiograph you will find a small radiolucency. So you will find a small radiolucency here. This is a radiograph at the furcation area with the pocket formation. So there is a periodontal tissue which covers the furcation, and therefore you can barely pass the neighbor's probe. So there is a periodontal tissue. I could have written it here, guys. So this is a periodontal tissue covering the furcation. And this is the reason that even though there is a bone loss, there is a complete bone loss from inside, but since there is a soft tissue which is covering, you cannot pass the probe. So guys, talking about the grade 4 of the Glickman classification, which is a loss of the attachment, you will see also the gingival recession. So there is a tunnel which exists between both of the roots. So there is a recession. You can actually easily see it clinically. So if you see clinically, you will find that, if you see clinically, guys, you will find that there is a furcation. So up till here you will be able to see like this. So you can see that tunnel from your naked eyes. So furcation opening is visible. Opening is visible. And there is a gingival recession. It is similar to grade 3, but there is a recession. Plus, I'm going to write grade 3, which exposes the furcation from the eyes. So you can easily pass the periodontal probe or the neighbor's probe from the one side, and you can see it from the other side. So there, the probe passing is through and through. If there is a through and through bone loss, that is the complete interradicular bone loss. So that makes it the grade 3. If there is a through and through vision from the naked eyes, then that is called as the grade 4 Glickman classification. How do we diagnose it? So we take the neighbor's probe, we have already talked about. We check the pocket, we check the attachment loss, and then we take the radiograph also. So guys, you are also going to take IOPR as well as the bite wing, and sometimes you do the transgingival probing, and which is also known as the bone sounding. So what you do is you insert the LA, and then because you are going to probe it into the bone, so that there is going to be definitely a pain, so therefore you are giving the local anesthesia beforehand. So you are inserting the probe till the bone. So you are going to see the base of the furcation with the help of a probe. So that is called the transgingival probing or the bone sounding. So guys, next coming to the treatment of the furcation involvement, right? So how do we treat it? There are three objectives. The first one is to facilitate the maintenance. So what we have to do is we have to facilitate the periodontal maintenance. How do we do that? So we have to maintain the existing furcation. Always in the perio, first thing we do is do the scaling and the root planning procedures. So we have to maintain the existing furcation. We have to maintain the periodontal attachment. We can also do it by obstructing the furcation. Also guys, we have to increase the access to the furcation. So second objective is to prevent the further attachment. So prevent the further attachment loss. We do not want the more attachment to happen, right? So we have to stop it. We have to stop the furcation involvement. How can we stop the furcation involvement? Again, we have to remove the plaque. So we have to do the scaling and the root planning. Then there is also some apically positioned flap. We can also make the area accessible to clean. So we can also do the gingivectomy or odontoplasty, osteoplasty, all these procedures. Then guys, the third objective we have to treat the furcation involvement is obliterate the furcation defect. So obliterate the furcation defect. That means guys, we have to just remove the defect. So suppose if there is a rotten tree or if there is a dying tree, so what do? We just remove it from. So this is not extracting it. So obliterating the furcation defect, we can do the root resectioning or the bicuspidization procedure. So we'll be talking about all these procedures. So root resectioning is what we do is we take out one of the root and then we remove this root. So I knew this is going to happen. So we remove the like this is a root sectioning. So root resectioning, root amputation. And also suppose this root was involved with the furcation, so we have removed it. The other way is guys, we cut the tooth into half and we also cut the crown as well, like this, and then take out the other half. So this is bicuspidization, hemi-sectioning. So all these procedure we are going to remove the furcation itself. So these are the procedures which we can do to obliterate the furcation. Or also sometimes what we do is we do the tunneling procedure. So we remove the bone, we make it through and through, and we give the patient interproximal brushes so that it is easy to clean. There is no plaque accumulation, so that there is no further bone loss which occurs. So class 3 defect, we open the tissues up and make it a class 4 defect so that there is no plaque accumulation, so that the person make it a self-cleansable area. So guys, very first thing a periodontal patient comes to you, do is scaling and the root planning. So first of all you have to do is either it is a surgical or it is a non-surgical patient, either it is grade 4 furcation, grade 2 furcation, grade 3 furcation, whatever furcation it is. First of all you have to do the non-surgical approach, which is the scaling and the root planning. So what you do is you do the scaling and the root planning for that particular patient. Now what happens once you are doing the scaling and the root planning? So it is going to treat the class 1 patient and also shallow class 2 patient. Shallow class 2 patient, the cul-de-sac lesions. So these will be treated with the help of the non-surgical. Now what about the other? So rest of the procedures, like we talk about the advanced cases of the class 2 up till class 4, we have to treat it via the other ways. So other ways can be guys, again what we can do is we can go for osteoplasty or then odontoplasty, osteectomy. So for all these treatment, what we can do is we are going to talk about certain treatment modalities. So first thing we'll cover the furcation plasty for this. So how do we do it? Guys? So first of all we reflect the flap, then we do the curettage, that is we remove the granulation tissues, then we do the odontoplasty. Odonto means teeth, plasty means to reshape, and also we can do the osteoplasty or osteectomy. Then we do the cleaning and the debridement, and then guys we do the We pull the flap apically and cover the furcation area. So guys, then we do the localized flap procedure. Localized flap procedure. Now this usually is helpful for the class 2 cases. Procedures. So this procedure is usually, we can do it for cases up till the isolated deep class 2 cases. For class 3 and class 4, so this is for the class 2. Right. For class 3 and class 4, what we have to do is, now class 3 and class 4 are rare cases. What do we get? For this is what do we do? One of the procedure is the tunneling procedure. So tunneling procedure is making the class 3 to class 4. Now you will be like, ma'am, why are we doing it? Why are we worsening it? We are, my lovely students, are not worsening it. We are making it the area clean. First of all, in my BDS days, when I used to read this, I had this horrible, terrible doubt in my mind that why are we worsening the situation? We are not actually worsening the situation. You have to just imagine it. Suppose this is a furcation involvement, okay? And the bone is up till here. Now what happens? This is bone is up till here. Now what happens, guys? There is a flap. So there is a soft tissue which is covered. So beneath this soft tissue, you will see that there is so much of inflammation which is occurring. So the area is, the patient cannot clean it. So what we are doing actually is, we are making it self-cleansable area. This is the same tooth. Then what we do is, this is the same condition, right? Then what we are doing is, if this was the bone loss, then we are removing this soft tissue. So now the patient can insert the interproximal brushes here and he can make it self-cleansable. So there is less of plaque accumulation. Since there is less of plaque accumulation, then there is a easy maintenance. So we ask the patient to use the interproximal brushes, and if you do remember, we have already covered in the previous lecture. I will just show you once that we have covered the interproximal brushes, if you remember. So these are the interproximal, like this we get the interproximal brushes also like this. So they insert it in the pocket and the flap and then they clean it. So this is how the patient is maintaining its state. So there is a less plaque accumulation, easy maintenance. So this is the reason that we do the tunneling procedure. Now guys, sometimes what happens when there is a deep vertical defect, deep vertical involvement, then we can go for the root resectioning or root amputation. So one of the procedure is root amputation or the root resectioning. What we do is, we remove a root. So resecting a root or amputating a root, you can take it any way. So what we do is, suppose this is a tooth. Now if you can see here guys, I am making a maxillary here. So that means we usually do it in a maxillary root. So this is one root. So guys, what we do is, we remove one of the root. So what we do, we cut down this root like this. So we amputate one of the root. So this is root resectioning. We remove the affected root. They need to clear the visibility for the surgery. So we make a window close to the root. We go in the oblique direction. And guys, there are two conditions. One, some people say that we have to make the tooth vital, so we have to preserve the pulp chamber. So if the tooth is vital, but usually what we do is, we want to play on the safe side, so we make the tooth non-vital. We do the RC so that it is easy for us to do. So the most common teeth we do the root amputation or the root resectioning is the maxillary first molar, and the root which we resect is the distobuccal root. So this you have to remember for sure. So the distobuccal root of the maxillary first molar is the one we take it for the resectioning procedure. Now guys, last one we have is the hemi-sectioning. So hemi-sectioning, we are sectioning it. It is not removal. If you say, I am not saying removal. So it is hemi-sectioning. Just the section. We are just dissecting it, separating it and keep it. We are not removing it. There is no extraction which is involved. While on the other hand, root amputation or root resectioning, we were removing it. But in case of hemi-sectioning or the bicuspidization, there are two roots. There are two roots, and if you can see here, we are drawing a mandibular. That means it is most common in the mandibular teeth. So we are dissecting it into two and therefore keeping both of them. So there are two roots and we are keeping both of them. So guys, this is root separation, bicuspidization, hemi-section, and we know that unity is the power. So we keep both of the root. We use the roots as an abutment teeth. So we are splitting a two-rooted tooth into two separate portions and we are giving a crown to both of them. So in case if there is a furcation involvement in the mandibular molars, and especially with the mandibular molars, we do, especially when there is a buccal or the lingual class 2 or class 3 furcation involvement. With advanced bone loss and interproximal area, or in which there is interradicular zones are not there is a bone loss in the interradicular zone. So in that case, we just separate both of the roots and we keep both of the roots or the tooth, both of them, and the tooth we use it at the abutment tooth. So the mandibular tooth we take it. So in case sometimes in the hemi section, what we do is, see guys, in the hemi section, if you see that there is two things. Bicuspidization is keeping both the cusp, right, and make it as abutment. But hemi section, sometimes we do it, we remove the most diseased root and we keep the good root and we use it as the abutment. So we section it in a mesiodistal way. So mesiodistal sectioning in case of hemi sectioning. And oftentimes, like they use it for both of the terms, hemi sectioning, bicuspidization, they use it for keeping. Sometimes when the both are different terms, then they have to use it. Hemi sectioning means removing the diseased tooth, keeping the good root. Removing the diseased root as well as the crown and keeping the good root as well as the crown. So sectioning in the mesiodistal way. And root separation or bicuspidization is when we keep both of the roots but we are separating it and we are using it as the abutment. I hope that you guys have enjoyed the video, and if you have any doubt guys, you can refer our website www.x2.com, and if you have enjoyed the video, then give it a thumbs up and also comment in the comment section below, because this motivates me to put videos as well as free lecture for you guys. And also you can support us on Paytm as well as on PayPal to make free videos for you guys. So till then, keep reading, keep learning, stay motivated. All the best for your exam. I'll see you soon in the next video.